My name is Lynn Rogers. I have been a nurse for a little over 13 years, but I have just been at Capital Caring I've been here about 3 years. At the beginning I was a volunteer, and I worked in the inpatient unit and also in the long-term care facilities, and then decided that this was a really special place and decided that I wanted to work here as a nurse as well. And I have been doing that for a little over 2 years. Before I did this, I was an oncology nurse, and I did some community-based nursing as well, immunizations and free clinics and those kinds of things. Nurses at Capital Caring we have several places where we work. We work at the homes of the patients, and that is whatever is a home to them. So it can be nursing homes, it can be assisted living, it can be homeless shelters, it can be like residences in these neighborhoods. We also have the inpatient facility in Arlington and the new one that's being built. We have some nurses also that are in the hospitals taking care of patients who are either already hospice patients and end up at the hospital and helping them with that to make sure that whatever symptom brought them there is managed, and also patients who are not on hospice yet but have decided that that's something that they'd like to do. We have nurses in the hospitals that take care of those patients and their families. Patients come from several different locations. So if a patient has not been on hospice before and they're, say, at the hospital, then one of our nurses would go in and tell them what we're all about, what kind of services we offer, and determine if they are an appropriate patient for hospice. There are certain guidelines through Medicare and insurances for what you have to qualify to be hospice appropriate, your prognosis, the kind of care that you want to receive, and the kind of care that you don't want to receive. You have to have goals that are related to hospice treatment. And so in that situation, a nurse in the hospital would help admit the patient to hospice. Then it would depend on the patient. Some patients go from that to home, and some patients go from that to our inpatient center. And some patients skip that whole hospital bit. People do go on to hospice who aren't in the hospital, who are at home already. At the inpatient center, we are a go-between, really, for many patients, between their hospital admission and being at home. So sometimes people have symptoms that can't be managed at home yet, so we bring them into the inpatient unit, help them get their symptoms managed, and then most of the time people want to go home, and that's the goal usually. So then we help them get there.
When a patient leaves the inpatient facility and they've been associated with a nurse here, do you follow up with them at home, or somebody else does that?
Somebody else does. We have home care teams we have many different regions. There's some in Maryland, Virginia, DC. So it depends on where the patient lives. And the home care team will be the team that takes care of them. The nurse here at the inpatient center will connect with that home care team and make sure that they know all about the patient, that they know what we've done here, what symptoms they've had trouble with, and how we've managed those, and just make sure that that transition is as seamless as possible. Yeah. If a patient comes to the facility and dies here, we also help the family after they're gone. So we have bereavement services, and our team here at the inpatient center connects with our Capital Caring bereavement staff and makes sure that any special needs that the family has are identified.
When a patient is admitted, how do you introduce yourself to the patient and to the family of the patient?
This is going to depend a little bit. When a patient first comes to our facility, what happens in that initial admission process really depends on the patient and the family and what those specific needs are. We are we're very patient and family focused, and so that's going to be different for each person. But always there's going to be the initial assessment from the nurse. We're going to fill out the paperwork that we have to fill out, and we're going to introduce ourselves, of course, and the other team members, give them a tour of the facility. Sometimes people come and they have out-of-control symptoms and they're having an emergency right then. We prioritize, of course, and take care of those things first and get people comfortable, and then we can go on with setting goals, prioritizing what will need to happen during the stay here, because these stays are usually pretty short. This is about a week is sort of the long end of the stay. And most of the time people are coming in to get those symptoms managed and then to get back to home. There are different kinds of nurses at the inpatient facility and also in the home care setting. At home care, you have a case manager. There's a nurse that's in charge of coordinating that team that comes in. That is, of course, going to be patient-specific as well. Some people will need assistance with personal care. A certified nursing assistant, CNA, can go out to the house. Some people will want to see a social worker or a chaplain. And it depends on what the patient and family need. Here at the inpatient center, we have a charge nurse, and we have at least one or two other nurses who are here for each shift. We have a day shift and the night shift. And then there are CNAs here as well who take care of our patients. And then here we also have volunteers they help with a lot of different things, but they help with the personal care for the patients. They help the CNAs with bathing people, for example. They help with being present for the patient. Some people want to have someone sitting and holding their hand. Some people don't want anyone to hold their hand, but they want someone to sit and watch the football game with them. Different kinds of things that just to give that support and that presence for people so that they're not feeling as isolated. Mm-hmm. We do have laws, the Hippa Laws, that require that we don't share protected personal information with people that don't really have a reason to know. For a volunteer, they are held to the same standards that our medical staff is held to, in that they're expected to keep things confidential that they hear here. So anything that they need to know in order to care for the patients, we do share with them. And the same thing goes for our entire interdisciplinary team, the doctors and nurse practitioners, the social workers and chaplains, nurses, CNAs, volunteers. Everybody is a part of this team to best care for the patient depending on their needs. So we do have to be careful with their protected health information, and for where that comes into sometimes is with families. Each individual is different. Many people do have a medical power of attorney, and that is a family member generally, or a friend, somebody that they've decided is going to be the person who makes decisions for them if they're not able to. That person may be the one who we're talking with, that we're sharing information with, depending on what the patient has said is okay. Some patients want their entire family to be involved in their care, to know everything, and they're very open. They don't want anything to be a secret. Other people don't want anyone to know anything. And we just we respect whatever the patient feels about those issues. Patients and families request all sorts of different things. We try as hard as we can to meet those requests if we're able to. Many times it's just it's answering questions, it's information that they're requesting to help make sense of everything that's going on, make sure that they understand the process of what's going on. Sometimes we have requests for assistance in doing certain celebrations. We've had weddings here, we've had anniversary celebrations and birthday celebrations, and those kinds of things can be really important for a family. And if your loved one is here in the inpatient center on an important day, we try to make those things happen if we can. Sometimes people want to go outside. The patients want to go outside. That's another thing our volunteers will help with. If a patient can't go outside. They can't be just left there by themselves, so a volunteer will go out with them and sit with them. Sometimes families like to be out there. We have a garden area that we have volunteers that do landscaping out there, and it's beautiful, and we have benches and a gazebo, and there are many people who really would prefer to spend most of their time out there. It's lovely. And we have families and patients. Sometimes it's as simple as getting a shower or having the patient's hair washed. Some of these things that seem so simple to us can make a really huge difference for people who are in the midst of this kind of really stressful situation. Each day, every shift is unique in the stressors and the acuity level of the patients and the different needs of what's going on the floor. And so the charge nurse for each shift will kind of take a look at the patients and the acuity level, meaning what's going on with them, how sick they are, what kind of special medical needs they have, and split up the patients to the nurses that are there. Sometimes, there are times when the relationships are more important. So if a nurse has been taking care of a family for several days and developed a relationship with that family, many times that nurse will want to keep the same patient so that he or she can continue in that trusting relationship, because it takes a little bit of time to develop that.
Yeah.
Our facility has 15 beds. So when it's full, there are 15 patients. And each nurse, generally the nurses will have 5 to 6 patients. The charge nurse will usually have less patients because he or she is doing a lot of other things in addition to patient care, coordinating all of the things that come up during the day and helping the other nurses and working on admissions and discharges, transfers, all those different things that happen during the day. So usually a nurse will have 5 or 6 patients, but it's not just the nurse, because there will be a team there of the nursing assistants as well who will help, and the volunteers who will help. So the nurse helping and all this whole group helping the patient. Team members do communicate with each other throughout the patient's stay, and the one thing we do is we have our interdisciplinary meeting, and our interdisciplinary team communicates with each other in that way. And then we also have our electronic medical record system, and we write in there, document everything that we do on the computer. So the other people who are on the team with us can pull up our assessments and what interventions we've done. We do have some paper still with our with our medications, so we write down what medications we've given and when, and that is helpful when somebody is coming. Like say the physician wants to come and see whether the medication is adequate. If the patient is needing a lot of extra pain medicine doses, whether that needs to be adjusted and those kinds of things. A lot of it is on the computer, and that's good too, because then the home care team, if the patient's going to be transferred, can look on there and see what we've done, what interventions we've tried, what the patient's response to those interventions was, and then they can really know what's going on with the patient as well. And it helps with communication. And then of course, if we're going to send a patient somewhere to the home, we're going to call the nurses and we're going to talk as well, so that there's not any confusion about what's going on. So an ideal interaction between the nurse and the patient depends so much on the individual patient and what their needs are and what their goals are. And you find that a patient, for example, might be very certain that what they want is pain management. That is their goal. They want to have no pain, and they're willing to be sleepy if they have. Sometimes people will get sleepy with the pain medicines while they're getting used to it, and that's fine with them. They just want that pain gone. There are other times when you'll have a patient who feels that no amount of sleepiness is okay. They want to be alert, awake, able to have conversations and understand what's going on, and they're willing to have a little bit of discomfort. So for those two patients, the ideal interaction is going to be different, because it's going to be whatever that patient needs, whatever that patient's goals are. So the ideal situation is going to be if we can meet those goals, if we can, learn, first of all, discussing with the patient what they really want from their experience, and try to make that happen for them. Every person who's coming into this system is going through a crisis, and a very emotional time. This isn't easy for anybody. And to make it more personal, to make it so that they feel like we care about how everything is going to go for them, that we care, that they know what the nurses do and that what the volunteers do. Those things, I think that it's important to us to do the little things that make such a big difference, so they don't have to be worried about asking, can I get up and take a shower today?
Right.
That's those kinds of. One of the things that they taught us in orientation, and I've heard it a couple times since then in various meetings and things, is that people feel like they're giving up and there's nothing else that can be done. And that's often how it's presented to patients and their families. We've done all we can do. Off you go to hospice. But there's always something else that we can do. We just have to help them in changing what they're hoping for. That maybe they're not hoping for a cure for the disease anymore. Although we do say that we don't do anything here that is going to make a miracle not happen. If a miracle is going to happen, that's good. We all believe that those things can happen. We're not that the hope, though, for pain relief or for anxiety relief or an easier time breathing, changing the things that they hope for, and then working towards those goals. Can really ease that transition. It is hard. And sometimes going through curative treatments can be it's a big challenge. That's physically very tough for a lot of people, emotionally very tough. Many times for years, people have put their entire family, this has been the project for the entire family, and the driving to and from appointments and all of these things, and then to have to transition not just away from that care, but away from that team that was providing that intensive care into a whole nother team with a whole different set of goals. It's a pretty big transition. Not even dealing at all with the idea of the loss, that impending loss. Yeah. Hopefully we make it a little easier for people. I hope so. This is not like any other work that I've ever done as a nurse or in other fields that I've worked in. It's so fulfilling. It can be beautiful to be here. The interactions that you have with individuals and the difference that you know that you're making. Sometimes it can be very emotional, and there are times when it can be extremely stressful. And that is in just the nature, I think, of working with other human beings. And it's important, I think, to remember to be gentle with yourself, to realize that you're just human as well, and to ask for help when you need it. I notice that I tend to want to fix everything. I want to make everything better for everybody. And I have to remember that that's me as well, and to ask for the help that I need. Part of our team is we have chaplains, we have social workers, we have the other nurses and CNAs and volunteers, and everybody is here to do this together. So whether it means just, I need a hug right now just to get me through this next hour, or if it's I need to talk things out more at length. There are some patients that you find are harder for you to work with. Maybe they remind you of someone who you've lost. But for whatever reason, there are going to be times when you need to talk things out and rely on the team. And the other people who are here working in this facility are having the same situations. So we help each other. And there's a lot of hugging. You know, there's a lot of sitting and listening whenever somebody needs to just talk it out.
Yeah.
And we encourage that from each other. We try to be aware of what the other people who are working here are going through. If somebody seems to be having a hard day, you know, picking up some of the work from them, maybe it's a particular situation that's touching them in an emotional way.
Yep.
We only get just this one chance to make this experience peaceful for the patient and for their family. And people will remember this situation. They will remember how the care that we provided for their loved one. And if they felt like things were out of control, or if they felt like things were peaceful and that their symptoms were well managed, they might not remember every little thing that you did or every word that you said to them, but they're going to remember how you made them feel. And that is an important thing to keep in mind, that there are times that are very stressful, of course, but remembering that we're not going to get a second chance on making the last days of this individual's life peaceful is an important thing.